here. There's everybody. So welcome to our Navigator Focus Series, Ethics and Advocacy Basics. So let's get started. I'm going to share my screen. And as you know, we've changed our introduction slide. It just used to say CA Bridge and Public Health, but I'm going to explain this just a quick second because you're going to hear two terms now. Although public health is our overlying organization, that's who we work under. We now have Bridge because, as you know, Bridge has expanded to other programs such as EDSP, our EMS bridge, our national bridge, our CA bridge, that's us, and access bridge. So we're all one big bridge, and our program fits under bridge and public health. So just wanted to clarify that. Today, the best experience we want you to have. So please, if you have a question, the one thing of all of these key points here is make sure you address your question to everyone. I still mess up on this, you guys. So if you mess up, no problem. We just want everybody to see your question because then we're answering and nobody knows what the question is too. So I struggle because people are direct messaging me, and but just make sure if it's a panel question, direct it to everyone. There is closed captions available through Zoom. We are here to talk about ethics and advocacy, but before we get started, I always like to give the background and our goal of Bridge, CA Bridge. We want to provide 24/7 access to high quality treatment of substance use disorders in all California hospitals. And we're really proud that we are up to 276. So very much almost covering California. If they're not one of our partner hospitals, we know about them and we can definitely refer to a hospital in the vicinity. So what is CA Bridge model? Well, we're revolutionizing the system of care. It is the standard of care specifically for California hospitals. Our approach is a three-prong approach. The first is low barrier treatment. That's what your doctors are doing when they are administering and prescribing buprenorphine. They know not to have urine tests and lab tests. Patient comes in and says, hey, I'm going through an opioid use withdrawal, and they get buprenorphine. It's as simple as that, right? Our navigators are instrumental. They go hand in hand. They're the left hand and the right hand. So the left hand's the doctor, the right hand is the navigator, and you guys are just working out there so hard with all the barriers and challenges, and you're connecting our patients to treatment, to care, to harm reduction. You're making sure that they matter and they feel like they matter. So again, I thank you for all of the hard work you're doing. You're navigating them to where they're at and where they need to be. So congratulations on all your hard work. And then your other, the last pillar is culture of harm reduction. That's for all of us, but I know our navigators are the specialists. You guys are out there every day being role models, reducing stigma for our patients that use drugs. So again, that's our very simple three-model approach. So we have some announcements. I am happy to announce we are going to have our CA Bridge regional collaboratives throughout the year. We are in progress of creating these and having a registration link. You will get more detailed information in the post email. So we will send that out after our webinar is completed. But we're really excited to promote these. These are going to be 10 in-person regional collaboratives. We're really hoping to come to a region near you. The first one's going to be in Fresno. That's March 13th. And again, more information to come. We have started a registration link and we can provide that in the chat. We have and Sacramento, and we're still in progress of confirming a date for that one. However, June and September and December, we will be having more in-persons. So please save the date, save the month. Know that we're going to be coming to a region near you. So we're really excited about announcing these. So you have an opportunity to go in your region. That's what we prefer. We understand sometimes you missed it and your supervisors say, you can go for training. It's okay. You can come to any. However, the one closest to you is going to be most beneficial because we will have resources and physicians that are in your area being guest speakers. So we're really excited. More information to come. And then we have our CA Bridge Regional Collaboratives. That's for everybody and anybody. Doesn't matter your region. We're going to have our first kickoff March 6th, which is a Thursday. Dr. Amy Milan, a founding director of CA Bridge, will be our opening speaker. So sign up again. These are going to be virtual. They're about an hour and a half. We will also have a regional breakout within that meeting. So you can talk to people in your own region. So these are new. These are going to be very much discussion, collaborations. So really, we look forward to these new formats, and your attendance would be greatly appreciated. So talking about our regions, we are still looking for some mentor volunteers. We still are accepting applications for Northern Bay. These are all up north, Northern Bay area and Southern Bay area. So if you're from one of these counties, please let me know if you're interested. It is to be a resource for our regional collaboratives, our meetings in person and virtual. So if you're interested, please let me know, and you can email me at mentors@cabridge.org. The one thing I did want to mention is we do have some of our volunteer mentors already here today. One is going to be presenting today, Katie Quijada. She is going to be representing Long Beach, Orange County for those regionals. I've seen Joanna Partita. She's San Diego, Imperial County. And there's others, and we're waiting to announce these regional mentors soon. So look for them on Slack. I'm going to get everybody to go to Slack and to see the list. We're going to post that today. So go to Slack, see the list of our regional mentor volunteers for our collaboratives. So today's objectives, all things advocating, right? Understanding policies, laws, and confidentiality for mental health and substance use disorder, and verbalized strategies. Sometimes this is a really hard road to navigate, is to advocate and not become overly aggressive or assertive, because some of these situations are something you're passionate about, and you need to take an approach to where you can get people to listen, right? This is really hard to navigate. So starting our day today, I'm going to give some words of Dr. Martin Luther King. Our lives begin the day we become silent about things that matter. And with so much going on in the world, this seemed really fitting right now. So no matter if it's patient advocacy, we become silent, right, about things that matter. So we kind of got to break that mold. So I'm going to start off with just, what is advocacy, you guys? What is it? I learned advocacy. It can happen at many levels, but I learned it as a little p and a big P. The little P's are things that we can do every day for advocacy. It's your individual actions. It's supporting patients. It's just everyday advocacy. Your patient doesn't have a certain form, so you're the one to advocate. They don't need the form. I'm here, I'll help them. Those are the little P's of everyday life that you advocate for, right? A patient doesn't want to wait in long lines, only wants to get a prescription. You're advocating for that patient. And then you have big P's. Big P's are things like hospital policy, legislation and laws, and systemic change. That's the big, huge P. So that's how they can be categorized. Today, we're only talking about the little p's, the things that are important to us, ourselves, our peer, our patients. Next time, our session 2 will be focusing on big P's. So today is little P's, and next week is, or next month is big P's. And can, in the chat, if you want to, you can give an example of advocacy for any of these categories, you guys. Specifically, if it's a big P related to substance use, if it's a little P, let us know what was an example. There are certain types of advocacy, and what is advocacy? It's the act or process of supporting a cause or proposal. And as I already mentioned, there's self-advocacy, patient advocacy, community advocacy, and policy and law. So what is an advocate? Okay, well, an advocate can be, you guys are putting examples in the chat. It could be asking to engage in community outreach for yourself, right? We hear this a lot from navigators that they they don't have approval. It wasn't approved for community outreach. It's asking providers to consider MAT. We still have lots of navigators who have that barrier and challenge. We're going to hear a story today from our next speaker, our next navigator, about proposing a naloxone vending machine, right, in their hospital. And then educating your prescribers about MAT, right? Some of them still think, there's that old word, you guys, what's that? The X waiver. There's certain laws, right? I'm not an addiction doctor. I can't prescribe. So again, I'm going to read some of these in the chat. Looks like everybody signed up. Getting cell phones for those that don't have one, definitely advocacy. Using person first language, don't judge patients. Transportation, yes, absolutely. So these are some great examples, you guys, and I know you live this every single day. And some of the methods are meeting with your management, your C-suite, presenting a case to the ethics committee. How many of you know if there is an ethical challenge and you do have to advocate, do you know the process to take a case to the ethics committee? Collaborating with community organizations, especially to get the word out about naloxone or fentanyl strips. That's advocating for your community. And then policy change for written letters and phone calls to your local legislators about things that are important for our patients. If you guys have any other methods, please put them in the chat. All right. Take a second to catch up. That was a lot to say, right? Okay. So coming up, I am happy to introduce a navigator in action. He has a story for us that it really shows what you guys are doing in the role as an advocate. I'd like to introduce Marcus Strong. He is from Palomar Medical Center. Marcus, can you please share your story about your proposal?
Sure. Thank you and good morning to everybody. So yeah, sure, I'll share my story about proposal of the naloxone vending machine. I'll start by saying my excitement for getting the vending machine and before the vending machine, I wanted Narcan to be ready and accessible to our patients at the hospital. That excitement came actually from me visiting doing my first bridge meeting in LA and doing their training. Some kind of way I left with the excitement of wanting to get getting Narcan just like ready and accessible. I had told some individuals I wanted, even my director at the time, I wanted it like a newspaper box. So that way, they can, when you go to the newspaper, free newspaper, you can pull it out. That's how ready, accessible I wanted the Narcan available at our hospital. Not knowing the logistics and policies at the time, just my excitement had kind of driven what I wanted. So we began to before getting the vending machine, of course, we went through the process of getting just naloxone Narcan at the hospital, which was, not the easiest thing to do, going with hospital policy, talking with the pharmacy, things like that. So I was like, this is really, it kind of became uh drastic, for lack of a better word. You're learning new hospital leadership, and they're trying to figure out, what are you trying to do? What are you trying to do? So you're coming up trying to tell them policy, and then they're fighting other policy with your policy and what you have. So it became pretty tough for me. So during the time my handoff hospital, they were asking me, well, what do you need? So I said, well, we Narcan. She said, well, what do we need? We got it. And then she asked, do you want a naloxone vending machine? And I was like, oh my God, yes, this would kind of help me with the struggle of getting, as we're getting the Narcan, it can be also ready accessible to individuals that need it faster than going through a whole triage process and getting seen by the hospital. Because as we, understand, sometimes patients will come in just for a moment, just for a rest. So I said, well, if they can come in during their time of getting their rest, they can get the vending machine right by their, they can get their Narcan right by their potato chips and their soda and leave out with what they need. So I was like, this will fix this, because of what I found out too was they felt like a lot of times they didn't get treated fairly while they were in the hospital. So the stigma was there, which I did not know was there until I, became more involved with staff and with patients. A lot of times they didn't like, how they were treated. So I was like, well, at least you may not know get how you're treated, but at least you can get what you need. So if you need Narcan as you leave, we're going to have it right here set up. And that was my idea, to have it right here set up with the vending machine. Get your break, get your nap on the chair, and then you can take your Narcan with you. Well, so I passed the information on to my supervisor, letting her know, like, hey, my handoff hospital has a vending machine for me. She said, we can get the vending machine. So she took on the project for me. And I was like, okay, cool. Now she's fighting areas of, leadership at the hospital for me, where I didn't know, what all else I can do at the moment. So later on, as she talked with individuals, talked with county agencies, talked with all the advocates per se, to bring Narcan for the county, she added me into the meetings. So of course we found out that our hospital location wasn't in the zone where they actually wanted a vending machine. So we began to talk about it. We may not be in the same zone, however, we have the same patients. So are we reaching the patients, or are we reaching, a political zone? So they begin to say, okay, well, we'll give you, we'll go ahead and follow through with the vending machine. So as we began to, talk about, hey, we need this, we need this, we need this for the patient, not for the city. And I was telling them, it's the same hospital that was downtown. We just moved to the other side. So they worked with us, and then they were willing to give us the Narcan vending machine. So then my supervisor ended up going, higher up to leadership, saying, fighting for the vending machine. And then, however, the leadership at the hospital declined our vending machine. So that was a unique process for us, though it went to a no. What I found out too was, what I began to do was show my face in the hospital. So they'll know now, hey, he's the one that's advocating for these patients. So I just began to show myself with leadership, the president of the hospital, the any event that they have, you're going to see me there. So there's now, I have the charge nurse. She asked me the other day, she said, Marcus, where's the Narcan at? Where's the Narcan at? So I have now other staff fighting for Narcan, for fighting for harm reduction materials for patients that they would have never, at per se fought for in the beginning. But now they've jumped to help me reduce the stigma for patients, so they can get what they need. So now the next time when we have a project where it's available, because I believe they all the vending machines that they originally wanted, of course, they're limited now. So the next time that we're up for it, I have now a team of individuals to help me fight for what we need. So that's what I kind of got out of that.
Thank you so much, Marcus. I just love this story because you guys, Marcus didn't give up. He could have just said, "Forget this." I didn't get the vending box. However, the work is never done. And now I love the fact that you say, "I make sure everybody sees me and knows who I am." And, that is so powerful in advocacy, knowing who you are and what you do. So again, just keep that momentum and that motivation. And thank you for sharing your story.
And I forgot to say, of course, we have it now, and a lot of the staff. I don't. You can see this. I should take thing off. but on your Narcan boxes where it says carry Narcan, save a life. So now a lot of staff have it on their badge to carry Narcan. So we're on.
That's wonderful. I love your story. Thank you so much for sharing. And like I said, if things don't come out, keep going. That's what Marcus did. It's not always a quick win, right? That's if
Absolutely.
anything, remember that story. Thank you so much, Marcus. All righty. Next, we're going to go to self-advocacy and patient advocacy with Chaia.
Can you hear me? Can you hear me?
Yes.
Okay. Hi, everyone. Again, my name is Chaia Vang. I am the Navigator Engagement Coordinator, and I'm going to dive into self-advocacy. So self-advocacy is a crucial skill that can make it possible for you to effectively represent yourself. So having knowledge, developing self-awareness, and knowing what your needs, your goals are in order to create a plan. You want to be able to communicate that. So having supportive relationships within your site, your department, your community, and network, and that is including us, California Bridge Navigators. Communicate assertively and clearly your thoughts and concerns and preferences in a calm manner when presenting your plan. That way others will respect you too. And practice assertive communication. I saw that in the chat, right? So have open-ended questions, affirmations, reflective listening, and then using I statements without sounding confrontational. Definitely you want to speak with facts rather than judgment. And then just showing empowerment, that is recognizing your own value and setting clear boundaries and maintaining a work-life balance. Learn to say no when necessary. If it's something that you cannot do, it is okay to say no. And then just being independent, showing that you have independence, standing firm behind those beliefs while remaining open to guidance at the same time. Just so knowing your role, understanding your role and what your responsibilities entail. I think Marcus has showed a very great example because he did his research and only spoke about the naloxone needs that were going to benefit the patients that he served, while he allowed for his supervisor to do the talking to the upper leadership. And then again, right, while you're doing all of this, you're going to, you have to prepare yourself to experience resistance. As this is the work that we all know, this work that we do in substance use is rolling with resistance for our patients and creating a community of supporters. So use that resistance as an opportunity to grow and explore in your role. So our ability to really advocate for ourselves impacts our capacity to advocate for our patients. And then that way we'll be better equipped to model and champion these same skills for our patients. So we're going to go on to the next slide for patient advocacy. Okay, so patient advocacy is a key role for CHWs, navigators, support specialists. You all know this already, right? Because we are going to be the ones who need to communicate our patient needs and challenges with that person. And then first of all, you want to be able to educate your patient by informing them the rights, the needs, and what the treatment options are. Providing them like even some mat services, what are the different medication options they have, and supporting the patient in their decision making. You want to be able to communicate your patient's health care needs effectively. And by doing that, you want to be able to communicate and coordinate with your care team, basically being that middle person. Support your patients, encourage them throughout their experience. And that can also mean navigating through the treatment system for them and then connecting to the resources. And then you are going to be the one that can provide the harm reduction support by letting your patients know that it is okay. You just want them to be safe, regardless of where the patient may be in their journey. So that is handing the naloxone to them right at discharge, or if it's something that you don't have, reminding your doctors, providers to prescribe it when the patient is ready to leave. And definitely, I remember a patient's dad telling me back in my days when I was still full-time navigator, after an encounter, that these were his words to me: "You were the only one who has ever treated us, especially my daughter, as a VIP in the hospital." And that really resonates with me when we advocate for our patients. So now that we understand how staff advocacy and patient advocacy connects to your work that you do, I'm excited to introduce one of our navigators, actually our regional collaborative navigator mentor, Katie Quijada from UC Irvine, to share a patient story that demonstrates the impact of effective advocacy.
Thanks, Chaia. So like Chaia said, my name's Katie. I am the substance use navigator at UC Irvine Medical Center. I wanted to share a story about a patient that I had that ended up becoming a systemic advocacy. It started off with my patient coming in, and I met with him in the emergency department. He was being admitted, and we talked about his fentanyl use and what we would do along his journey during his hospitalization. And he told me that he really didn't want buprenorphine, that he had tried it in the past before. It didn't work for him. He had really bad precipitated withdrawal every single time. And he had been successful on methadone in the past, but hadn't been to the methadone clinic recently. So I brought that information to his treatment team and I said, "Hey, is it possible for us to get him started on methadone?" And there was a lot of back and forth. The doctor said, "I don't know if we can do that. Is it in our policy?" And then they did try to do it, and the pharmacy put it back to them and said, "Hey, it's actually illegal for us to give methadone inpatient for addiction." And I ended up consulting the National Clinician Hotline because I was like, that doesn't sound right to me. And they were the ones who told me that we can start patients on methadone inpatient. It's totally legal to do so. We're just not allowed to do so in an outpatient setting that's reserved for methadone clinics specifically. So I brought that information back to the team. They were able to get him started on methadone, but then the problem became getting him into a skilled nursing facility because all of the Orange County skilled nursing facilities and the ones in the greater LA area have an issue with patients who are on methadone for addiction. They don't want to take them, or they say they can't take them. They come up with reasons for saying they can't take them. And that was a whole barrier that had to be addressed with like a multidisciplinary team. The case managers, everybody had to get involved in that. But I was able to get this one patient on methadone, and I thought to myself, okay, I have multiple patients who are inpatient who are asking to get started on methadone who have complex pain needs, meaning that they're on opioid pain medications for whatever reason that they're hospitalized for, a trauma, getting hit by a car, etc. Who are asking to get started on methadone, but the providers are choosing to start them on buprenorphine instead. Either interrupting or changing their pain management to accommodate that for their withdrawal. So I was so frustrated. I remember I emailed LaToya and I was like, I can't stand this. Why aren't we doing this with our patients? And I went to my clinical supervisor and he suggested that I bring it up to APS, not Adult Protective Services, but Acute Pain Services. The inpatient anesthesiology team that reviews all of the different like naloxone administrations and our opioid administrations in the hospital. I brought it up to them and I said, "Hey, this is a doable treatment. It's a safe treatment for patients, and we can discharge them and have them follow up at a methadone clinic. So there's already a route that we can be doing here." And ultimately, they agreed to it. And I was really surprised because I had been seeing pushback. I tried initially at the provider level, and I was getting pushback. And then I tried going to my clinical supervisor, and he said, "Let's bring it to these people." And Now we have a process in place at the hospital. If any patient is started on methadone for addiction, they're seen by pain services, the anesthesiology team, and the anesthesiology team knows to talk to me to be able to get them connected to a methadone clinic when they're discharging. So now we have an entire new option for Matt in the hospital that started with patients asking for it, but ultimately ended up coming to fruition because of my advocacy.
You know what, Katie, that's a remarkable story. Kind of, sets the tone with Marcus. These are not like wins. These are advocacy. This didn't come overnight. It was continued. And that's with Marcus. That's with Katie's story. And these resonate because you guys are doing this right now. So there is light at the end of the tunnel. A no is not no forever, right, Marcus and Katie? A no is not no forever. It's having perseverance. We should add that, Chaia, to our slide when she was talking about advocacy for patients. It's perseverance. You just keep at it. And so, any questions before we move on for Katie, Marcus, or Chaia, you guys? I love the comments. Thanks, great job, amazing story. That is amazing. Um, you know, people have been advocating for low barrier treatment and access to harm reduction. And again, your guys are, Marcus, your story is inspirational. This is amazing, you guys. This is what you're doing every day. And I just, I'm so grateful for people with such passion and perseverance. So excellent. We're going to move on. Just more thanks, Katie. Thanks, Marcus. I think these stories resonate with our audience, definitely. Next, we move on to LaToya. So hold on, my computer just did something. I don't know. It's not letting me press buttons. Advocating for privacy, LaToya.
All right. Thank you, Sherrie. And a really great story to just reiterate the importance of the advocacy. And I want to highlight something really quick before I move forward with the ethics part. Katie mentioned reaching out to me when she was going through, this whole situation, and I could really perceive the frustration of her wanting to help this patient so much, and knowing and realizing that it wasn't going to happen in that timing. And I want to also just point out that mentorship is super important. Sometimes you're doing all the right things, but maybe you have a little bit of doubt where you are thinking, what else can I do? Reach out to somebody, reach out to us, and we can talk it through and we can figure out together if you're doing all of the steps that you possibly can do, or if there's anything else and any other support that that is available. So, okay, on to the next slide. So, when engaging patients with ethics and when engaging with patients, ethics and advocacy really do go hand in hand. So we're going to take a look at what some of those ethical principles are, and they might sound pretty familiar because, again, they really do go hand in hand. So when we're talking about ethical principles, we're saying, how important it is to act with integrity, being honest, and we're also talking about competence. So having competency in the role that you're in, and not stepping outside of your scope for SUD navigation. When you are not, for instance, a licensed clinician, there are limitations to what you can do. So understanding what that scope is and staying within the realms of your scope is really part of maintaining your ethics. Fairness. So when it comes to fairness, acting in fairness means to treat all people with respect, with dignity, not being manipulative and trying to persuade somebody to do something they don't want to do, being transparent and being equitable. And lastly, when it comes to notable principles, taking accountability for your actions. If you made a mistake, it's important to own up to it and then work collaboratively with your team to figure out a solution. And sorry, one second. And then so with that, as a person navigating patients with SUD, you have a duty to the client, to the patient. You have a duty to the person that you're helping, right? So you always want to act in what's in their best interest, not your own, of course. We heard earlier about patient advocacy, which covers communication with the patient. So it's really important to ensure full disclosure of the details that are relevant to that patient, and making sure that you're respecting what they decided on for next steps. Excuse me. And then not only will you make sure to educate the patient on their rights and treatment options, like we heard Chaia mention earlier, but you'll ensure that you maintain confidentiality at all times. So that confidentiality piece is really critical. So as an example, say you have a patient who has a PICC line and they self-disclose that they use drugs intravenously. You might have a situation where the provider mentions they don't want to send the patient home with the PICC line because they'll use it to inject drugs. This might be something that you've come across before, right? Like this might be something you've actually encountered. So I invite you in the chat, and as I continue to move forward, I still invite you in the chat to weigh in when this scenario comes up. Is a perfect example of when you can, use your advocacy and honestly your good ethics, but use your advocacy skills for the benefit of this patient to advocate for what it is that they need in their care plan. So in the chat, if you can just kind of weigh in a little bit, consider how you would advocate for this patient. And I'm interested to see what a few of you might say. There is no really right or wrong answer here. Each individual person is going to advocate a little bit differently, but keeping some of the things that we've talked about so far today in mind, drop in the chat maybe a quick line of what you might say to this provider or how you might advocate for a patient in this scenario. I think I heard a hand go up, but I don't see it. But I invite you to use the chat while I move on to the next slide. All right, so confidentiality, I mentioned this already. Confidentiality is super, super important. So ensuring that we, as people who care for others, help maintain the privacy. And so maintaining that privacy helps to build trust and allows that patient to feel comfortable opening up and discussing sensitive issues without fear of their information being shared without consent, right? So maybe they feel a little bit more comfortable sharing with you about their substance use. They might disclose more substances that they use than they did with the quick check nurse or with the provider that they just saw, right? So building that trust and kind of giving that confidentiality disclosure and truly sticking to the privacy policy can really go a far ways when engaging with patients. This is especially crucial in situations like domestic violence, sexual assault, or especially when a fellow colleague is seeking treatment. I can say that I had a situation with a nurse at my hospital that was seeking treatment And I'm going to say on the DL, but for those that may not know that, that's on the down low. They were trying to privately seek treatment for their opioid use. They're a nurse. They're pretty well known. So they realized that they needed help. They felt comfortable coming to me to ask for help. But I had to do my best to maintain their privacy and confidentiality. And I had to make sure that I wasn't jeopardizing, anything for them. And they were very fearful of that, but still entrusted in me. So again, in this situation, I would want to be mindful of who I am discussing this particular patient's treatment plan with. And always keep those confidentiality considerations in mind. So you'll want to determine, is the communication that you're sharing, is the information that you're sharing within the hospital, is it necessary, or is it gossip? Am I going around telling other nurses like, hey, so and so just came and like hit me up for treatment options? Did that person need to know that, or am I now gossiping? Very, very important things to keep in mind and consider. Also following your organization's HIPAA and privacy policy. This is not necessarily just the confidentiality laws, but truly about privacy. Again, is it necessary to disclose this information? What information is necessary to disclose for a referral? We want to keep in mind to only disclose and share what is absolutely necessary for the purpose of the referral, and with the care team, not beyond the care team. And so when we're documenting, we want to keep that in mind as well. We want to document objectively, not subjectively. And so objectively are facts, right? And then subjectively is mostly opinion. So when we are writing an objective note in the chart, you don't want to summarize. You want to be specific. You don't want to make any kind of interpretation or kind of assumption about what the patient is saying. You want to use exactly what they said. And you do that by putting it in quotations, patient stated, whatever the statement is. So say patient stated, I need detox. So you would put that specifically. If patient stated, I have schizophrenia and I use meth so that it quiets the voices, you'll want to use those specific words when documenting what the patient is saying. And then also still consider, is it relevant information to put in there? We don't want to, create a whole dialogue in the EHR about what everything the patient said. So this does include if the patient uses colorful or unsavory language. So if the patient, uses a cuss word, if that's their specific statement, include that in there. You can use some asterisks or leave some letters out to, not fully spell the cuss word, but you want to really respect what it is that the patient is saying. And that's pretty much it for this part. I'm going to just really quickly, because I do see that there is something in the chat. So we did get some input on how a navigator would engage with or advocate for a patient in the previous scenario that I gave. And so I'm advocating for the patient to go to respite or maybe stay longer in the hospital for when the PICC line comes out. And then there are some other long-term injectable medication options as well for treatment if that's what the patient wants. But most importantly, we want to talk with the patient, establish trust, figure out what it is that they're wanting, and then use our ethics and our advocacy skills to carry out what those patients' wishes are. So next up, we have a really great story about a navigator who did some self-advocacy. We heard a little bit earlier about what self-advocacy could look like, and now we're going to hear this really great story. Oh, from Erika Bravo at Bakersfield, Adventist Health Bakersfield.
Hi.
Adventist Health Delano.
Adventist Health Delano, yes. Hi, my name is Erika Bravo. I'm a program manager actually at Adventist Health Delano. I've actually been working for Adventist Health for a little bit over 3 years within our whole Kern County area. So I've also worked at Adventist Health Bakersfield, Adventist Health Delano, and now at Adventist Health Delano, I mean. So I actually applied for the CHW application, which is kind of what I wanted to talk to you guys about today. Um, I actually received it through Bridge, like back in July of 2024. And it was actually meant to help us get sustain our program at our hospitals. During the same time, Current Health Systems was also accrediting for CHWs at our local college, which is Bakersfield College. It was a semester long courses, and it was about $1,000. Our hospital really encouraged us to enroll for the program, but when we asked if they were going to be able to compensate us or reimburse us for it, they ended up letting us know that they wouldn't, and that it would be a good opportunity for us to have it. So I actually reached out to Bridge, specifically LaToya, and I asked her a little bit more information because I had already got the certification by Bridge and asked if this would be valid for current health systems to accredit, and just kind of give me an idea of what the certification entailed. She did let me know that it was actually a curriculum that I was approved by DHCS, so it was a good certification. So I let my grants department know, that I have this certification as well from Bridge, and also I wanted to ask a little bit more about what they were looking into when it meant they wanted a CHW. So I was able to get a little bit of answer. So I explained hey, I have the certification. It is from Bridge. The curriculum is accepted by DHCW, and I think it would suffice to meet the need. Later on, a couple of months later, we actually got an email from our grants department asking us to apply for the Current Health Systems HW accreditation. And I submitted my application with my certification. And during that time, Current Health Systems also attended the CalBridge office hours just to learn about the sun role, learn about what we did as a sun, and then also to kind of understand as well what the curriculum for CHW was. Um, Couple of days later, I actually got a notification that my application was denied. But Bakersfield we have also two sons in Bakersfield, and theirs was approved. So I didn't really know what was going on with mine, why mine got denied and not theirs. So I reached out to Mandy Herrera, which is the program manager there. She's also a son, and kind of compared applications to see what I did wrong. How can I compare it to her? So I filled it out again, sent it over. And again, it was denied. So by this point, I didn't know what to do. I was like, why is mine getting denied? If it's the same application, kind of has the same information. So I just kind of decided to pick up the phone and call Current Health Systems and reach out to the coordinator there and asked her what they needed from me, or why was my application getting denied, and if it was from Adventist Health. She wasn't really able to give me a lot of information just because of legal reasons, but she kind of just hinted at the fact, even though you're Adventist Health, all sites are different. We have different contracts for different sites, and you might need like an NPI. So I kind of realized like, okay, this is what you want. So I called LaToya back and asked her like, hey, what is the NPI I need? Um, is Bridge going to give me the NPI? She kind of very kindly told me, it's like, no, the NPI that they're probably needing is the one for you. Like your supervisor would be the one that to be able to give it to you, or the hospital. So it was like really a back and forth situation. So I called Current Health Systems back, and I really was like, well, which one would you like? Which one do you need? And she very kindly helped me and just said, just give us the one that you can get. Apply for it again. And then afterwards, like, I'll call you back and let you know if it gets approved or not. So I said, okay. Before I did that, I did really reach out to my supervisors, and I kind of asked them like, "Hey, like mine's getting denied. I don't know what to do." So there wasn't really much guidance, unfortunately, from my supervisors. So I just kind of like took the wheels and I said, "Okay." So I reached out to our financial manager, and I just asked like, "Hey, what is the NPI for the hospital I'm trying to do, get certified or accredited by Current Health Systems, and they're asking for an NPI. Can you help me?" And he was very kind. He gave me the NPI. I entered it, sent it over. And then a couple of hours later, her name, the Current Health Systems coordinator that I had been speaking to for quite some time, called me back to let me know that it was approved. So I got a letter like that same day letting me know that my CHW accreditation was approved for Current Health Systems. And then later on, we found out that the reason why we were getting so pushed for the CHW certification was because our hospital was looking into getting funding through them. So in a sense, I was able to save some money, but as well, like explaining to them, like, what we do at Bridge and as a Sun role really fits the criteria for a CHW, and just kind of explaining them that, we do a lot for our patients and we see patients. So it really worked out.
You know what, Erica? Thank you. This is Sherrie. And, that just brought it home because the other day, a few weeks ago, we had Kern Health come to one of our office hours and ask us directly, what do we do? Do your CHWs see patients? So, it really does come full circle, and advocating, as you can tell from all of these wonderful examples, and I thank you, Erica, very much for sharing your story. We all have to advocate in some way, shape, or form, right? It's not as easy. And Erica took so many steps, all of our navigators, all these different steps and stories. This is what we wanted to show you guys, because the fact that we know that your road and the role you're in is all about advocacy. That's what you do every single day. So I thank all of these navigators for sharing their stories. I hope you gain some insight. But any questions out there for any of our panel, any of our navigators out there, any questions that you guys have? You could tell they have lots of experience, and specifically advocacy experience. Anything that resonates with you guys that you want to make a comment or have a question in the chat? We have just a few minutes. Our speakers were excellent and abided by all the time limits. So you guys are awesome. I thank you. Erica, I apologize for putting Bakersfield and not Delano. So please, if you think of Erika Bravo, she is at Adventist Health Delano.
Delano.
Delano. I'm sorry. All
It's
right.
okay. It's a small town, but it's beautiful.
All righty. Thank you. All right. Well, before we leave, here's just a knowledge check. You can answer these questions. It's essential to know your organization's policies and procedures. That's always true, you guys. You can help me in the chat here answer these. If you have an ethical dilemma with a patient, you should ignore it. What do you guys think about that one? Promoting your services is a form of advocacy. What do you guys think about that one? Yes, people don't know what we can offer them. You guys can save a life. As a CHW navigator or peer support specialist, you should know your community's low cost to no cost resources. What do you guys think about that one? Of course, it's true. That's advocacy. You're giving people options and choices. And ethical situations are challenging, but there are tools and policies to guide you. As you heard, all of these navigators asked for help, whether it's from their peers, their supervisors, the organization, outside community organizations. We all need support and we all need tools and we all need help. So don't ever hesitate. As Erika reached out to LaToya, please reach out to us. Like I said, we have so much knowledge in this group of navigators, and you guys out in the audience, I know you have so much experience to share. So we couldn't have everybody, but I do hope that this help guides you on your next advocacy project, right? So just want to give you some resources. You guys know CA Bridge, we offer free CEUs on that CA Bridge Academy, and I'm going to leave that up for just a few more seconds long. So always welcome to have free trainings with CEUs, and you can share it with your nurses and doctors. There's also some specific training for them as well with CMEs and CEUs. So we're always happy to share. And as usual, we are here for you if you need any help or any guidance, and even some practice with advocacy and talking to your supervisors or presenting at a community meeting or your own organization meeting. Let us know. We're here to help and support you. You can get a hold of us, mentors@cabridge.org. And I thank you. We hope this has, really enlightened you and makes you kind of have more confidence to move steps with advocacy in your role. Thank you so much, and we will see you soon. Bye.